Good afternoon, everyone. Thank you for joining us for one of a series of podcasts on topical issues in pediatric spinal deformity surgery. My name is Colin Nnadi. I'm a spine surgeon from Oxford, and I'm joined by a group of international experts. And our topic today will be metallosis in pediatric spinal deformity surgery. So before we begin, we'll just go around and introduce each other. So Terry, starting with you.
My name is Terry Ishmael. I'm a pediatric orthopedic and spine surgeon at Shriners Hospital for Children in Philadelphia. Happy to be here today.
Good morning. It's Charlie Johnston from Dallas. I'm working at Scottish Rite Hospital, and this is now approaching my 38th year here.
Peter?
And I'm Peter Cundy from Adelaide, Australia, and practice both pediatric orthopedics and particularly pediatric spine surgery. And we've had a long interest in metal ion release in children's scoliosis.
Right, thank you. And I practice in Oxford, pediatric spine surgery. So metallosis is becoming a recurring topic now. Particularly with failures around some of the more recent growing rod products. So I think this is a really good opportunity to discuss what impact it has, what the consequences might be, and where we see this going for the future. So Charlie, do you want to start off?
Sure, thanks. I thought the best way maybe to start the discussion is to kind of go back and review the transition of metal alloys in spinal implants over the years. When I first started, of course, everything was stainless steel alloy, Harrington rods, Cottrell Dubuisset. And over the years, it's transitioned to titanium-based alloys and alloys that include other metals, such as cobalt and chromium. And I thought it would be interesting to ask our group to review, the pros and cons as they see it of some of these various alloys, because obviously the leaching of ions from the metal is probably one of the major concerns and the reason for having this podcast. So, Peter, for example, do you have any ideas about pros and cons?
Yeah, thanks, Charlie. I suppose our initial work back in 2010, again with the all stainless steel type components, and at that time we were using isola, was the release of chromium ions from the implants, and we had a study which showed at about 5 years that over 1/3 of children had raised chromium levels in their blood, and that probably led us down a path. And as you quite rightly said, as time's gone on, it's been the titanium pedicle screws and either titanium rods or lately the cobalt chrome rods, which we tend to put in because they're stronger and stiffer and we can obtain more correction. What probably got us a bit excited was that we did a number of studies, and we've got over 8 publications on it now, but was when we looked at the group who had all titanium implants, so titanium pedicle screws and titanium rods, that we were finding levels of chromium in their blood. It was probably the first real finding that we had. And that led us down a path to discover what that was from, which we can talk about later. And probably the second thing that I suppose is my biggest concern is our latest research showing that the titanium levels remain raised universally out to 2 years in these children. So I might just leave it there, Charlie, if you like, and move on where you want to go.
Well, the next question, and I would ask again, Terry and Colin as well, is do you have the perception that there is an infection issue, that the titanium-based alloys have less susceptibility to infection compared to the older stainless steel? Is this a reason for switching or the evolution to the more titanium-based alloys?
So if I may go first, I think my predecessors in Oxford actually carried out a study on this a few years ago, and I think their conclusion was the development of the biofilm over the titanium rods was different to that of the stainless steel rods, and therefore the infection rates were lower with the use of titanium. How that then plays into the metallosis problem, I suppose that's open to debate, but that's my perception, that susceptibility to infection with titanium is less.
That's been my understanding as well through, looking through the literature. There's also, the increased ease of imaging the spine with titanium. You have a little bit less, metal artifact if you're trying to get an MRI to, take a look at the spine itself. So, I mean, it's multifactorial.
Well, the reason I bring it up is really that in the era of the growth-friendly instrumentation, and let's face it, that is the big elephant in the room right now, because of devices which are perhaps moving, are going to create an environment, it would seem relatively obvious, that there may be more ion leaching and more metal debris from these devices. And with the advent of the metallosis findings that we see, for example, in the vector, in the traditional growing rods, and the magnetic growing rods, that the amount of debris and tissue reaction would seem to counteract, at least in my mind, any advantage that titanium-based alloys would have, because they are so apparently inflammatory. I'd be interested in your comments on that. Peter, do you have any thoughts about the inflammatory process that's part of the metallosis?
Yeah, Charlie, I think that's a good point. There's a lot of evidence that the debris does, that we all probably see when we do removal of implants, we do see that metallosis. And I'm fairly confident if we do see that, that's also a sign that those metal ions are not just locally there, but they've also released to the circulation, and that they are spreading through the bloodstream. And I am strongly suspicious that they are deposited in the liver, spleen, and lymph nodes. And certainly with the work we've done, that we are seeing continued release of titanium from what are static implants. We're getting away from the growth rods now, but in the static ones, with probably reasonable evidence there's a solid arthrodesis there, we're seeing a fair homeostasis of raised titanium levels. So I suspect they are in the liver, they are in the spleen, and there are good studies. There's a very good study by Pele looking at 15 cadavers, and they could identify by surface electron microscopy titanium dioxide particles in the tissues of liver and spleen. And there's good evidence that also deposits in cardiac muscle. So it is fairly uniformly distributed within the human body. And as you know, titanium is not really a it's a non-biological substance. We don't need it for survival, whereas chromium, we need that for our enzyme actions. Titanium's not an essential element in the human body. So I think these people are being exposed to it. We've got our study group out now to 2 years, and we've just got IRB support to run these children out to a 5-year repeat assay. But certainly at 2 years, it's fairly standard at about 2 parts per billion, mean values of 2 parts per billion sustained levels of titanium.
And would you speculate on the shall we say, the danger of having 2 parts per million in the serum, or probably higher levels in the tissues that you mentioned?
Yeah.
As well as perhaps all of the debris that we see around the implants when they're revised?
Yeah, look, Charlie, I was really surprised when we first started doing this work. I thought there wouldn't be the release because, as you know, with the metal-on-metal hip prostheses, we do see raised levels of chromium and cobalt. The really good thing is we've found that the chromium levels go down to baseline by about 12 months. So chromium doesn't seem to be still raised with spinal implants in children. But my concern is the titanium, which remains raised. And particularly, as you know, about 80% of the children we're doing are female. And commonly, they're probably 14, 15 years of age. Now, there is evidence, and probably quite good evidence, that titanium does cross the placental barrier. So there have been studies done where they'll measure the titanium levels in the placenta and then measure the titanium levels in the first stool or the meconium of the infant. And it is detectable in the first stool and meconium. So titanium does cross the placental barrier. So potentially, if a pregnant mother has got spinal rods in place, they are exposed to raised titanium for the 9 or 10 months of the pregnancy. Now, what we're hoping is that our 5-year study will show that the levels are coming down and close to baseline, but there's no sign of that as yet, that they're coming down. So that's probably my biggest concern, because there are good models in rodents showing effects on fertility, certainly genotoxic effects of titanium. I suppose the other thing to throw in is where titanium is used, and as you probably are aware, it's a common food additive. Well, it has been a common food additive until now. It's called E171, and it's used primarily to whiten foodstuffs. So it's commonly put in to bakery items. It's a lot of it in toothpaste to make the toothpaste appear whiter. And it's also prevalent in cosmetics, but the skin absorption isn't very high. So initially enough, the European Commission has now stopped the use of titanium as a food additive for whitening purposes. It's still allowed in the US with your FDA, but from February this year, 2022, it's been prohibited in Europe as a food additive. So they're probably recognising the potential effects of titanium in food. So it probably should increase our concerns about what we're putting into these children's spines, I think.
So is it safe? Go ahead, Terry.
That was Colin.
Oh, Colin.
Oh, sorry. So I've just got two questions to the group. Well, the first is, have normative values been established of titanium? Because all the papers you read, although there's concern expressed about raised levels, no one's actually stated, well, these are the normal ranges that we expect to see. And this is what we're seeing. The second thing is, I think this is this is a massive topic which has serious consequences. So we've already had, the magnetic growth rod suspended from use and then brought back because of concerns about the metallosis problem. And then we're told, well, you must change them after 2 years. So where do we see this going in terms of the future of pediatric spinal deformity surgery? Because these children, a lot of them will need surgery. They failed conservative measures. And now it's coming to light that actually what the mechanism by which we're treating them may be generating serious future problems. How is this going to affect the specialty?
Yeah, I think it's very hard to know. Every laboratory differs in their assay methods, and that's partly why we've stuck to one laboratory in Sweden for all our studies. But there can be enormous variability in levels measured by different labs. And secondly, no one really knows what the safe level is. The Dutch have done some very good work on the amount of titanium that we all consume. And interestingly enough, the biggest consumers of titanium in the diet is the 2 to 6 year old children. And they're fairly confident that it's coming from the toothpaste, because as you know, when you're brushing your own children's teeth, they tend to swallow the toothpaste, whereas we adults tend to spit it out. So they've calculated their relative dose that they consume is around 0.67 milligrams per kilogram per day, whereas old people like Charlie and me, we're probably consuming about 0.07 per day because we're spitting our toothpaste out. So there's enormous variability in consumption. But what I really hope that we'll see is the titanium levels do start to normalise somewhere between 2 to 5 years, which would hopefully push most people into a safe zone. But I don't know where to direct things really at the moment. It's very difficult to know, but I think we need to be aware of it. And I think the other group to be aware of, there are lots of other implants which also have titanium on them. A lot of the plastic cages we put in people's spines have a nanoparticle coating of titanium to aid with implant adhesion to bone. So there are other sources of titanium, not just in our spinal rods and screws, but also in some of the cages we implant in children's spines.
So would it be, a reasonable assumption that elevated serum levels of these metals, particularly the titanium, which Peter has so elegantly demonstrated hangs around for 2 years at least, is going to accumulate probably in solid organs, as well as, especially with the growth-friendly mechanisms where there is movement and metal debris and the inflammatory process around the devices. These are going to be, I don't want to say gold mines, they're going to be titanium mines, which will be implanted in the body now for as long as those devices remain. So is there a justification, for example, to remove and debride these devices to try to eliminate the titanium mine? Do you think that this is appropriate?
That's a very difficult question to answer.
Yeah, we're all
in your own practice.
Yeah.
In your own practice, what would you be comfortable with? Terry, Colin?
Well, I have to be honest and say, my hope is to operate as little as possible. So I accept that for the early onset group, you expect to perform a few surgeries, but then once they've gone into the adolescent stage, then my message is it's one definitive procedure and that's it. And I kind of think, well, if it was my child, would I want them to come back for another operation? No, I wouldn't. So how do you get around that? I don't know, but this goes back to my question earlier, that this has serious implications for future practice.
I would say, like, in the few conversions that I've done, I've definitely, borne, witness to, the extensive metallosis, and whatever I see, I'll take out, obviously, as safely as possible, just to kind of, decrease the burden. But, again, I haven't really figured out what the right answer is going forward. Because, all the screws that we use are made of titanium, and Dr. Cundy's studies have shown that even if we use chromium rods, there still is elevated titanium through interaction between the screws and rods. So what's the answer? We also know that we can't take the hardware out because, we have recurrence of deformity. So,
but Peter's studies are primarily of patients who've had definitive fusions and have devices which are presumably fused and are not moving.
Right.
So, Peter, have you incorporated this into your practice? Removal and debridement.
No, I don't. And I do advise the patients and the parents that metal ions do circulate. I tell them that to date we've got no evidence of any deleterious effects of that. And perhaps I liken it to the old days when we all had amalgam fillings, and there's evidence of some release from metal from that. There's evidence of metal ion release from patients with dental bands on their teeth. And we all ingest it with various foodstuffs. So I think the difficult thing, Charlie, is to know whether there's an ill effect, and particularly the potential teratogenic effect on the unborn child. And we really need really big numbers to prove that. So that's going to be difficult to achieve, to get enough numbers together to show some birth defect from these.
It would almost require a sort of a public health study of an entire nation or an entire continent to try to see if patients with birth defects, for example, have had exposure in some way.
Yeah.
And I think, in kind of closing this discussion, we have to remind our listeners and everyone that we don't know what the effect of the elevated titanium is at this point.
Correct.
And perhaps this is the major issue now to be investigated by organizations like the Scoliosis Research Society, since we're the ones who are putting these devices into patients.
And then I suppose one more food for thought is, should we be advocating routine blood surveillance post-definitive fusion, or even biannual biopsies of peri-implant tissues as a screening method, just as is done for other conditions like cervical screening and things like that? Should we be advocating that? Because we know that there is a potential problem. What are we going to do to try and avoid that?
Yep. All great food for thought.
Yeah. So I suppose I'd like to thank the guest speakers for joining what has been a really interesting session, and I hope that our listeners have had an opportunity to listen to the wonderful and vast experience on display here. But I think this is certainly a topic that we're going to hear more and more of in the future. So again, I'd like to thank all the speakers for sharing this forum with me. Thank you.
Thank you
for having us.
Thanks, Terry. Thanks, Charlie.
Good. Thanks, guys. Great to see you.
Thanks. Good. Yeah.
The Scoliosis Research Society is a nonprofit professional organization made up of physicians and allied health personnel. Their primary focus is on providing continuing medical education for healthcare professionals and on funding and supporting research in spinal deformities. Please visit srs.org for further information.